How to recognize the shocked patient? It might sound like a silly question, but actually this is a really hard question to answer. Shock actually may not that easy to spot all time, and sometimes to diagnose a case of shock, it is not always that simple, because there is no single vital sign or lab test on its own that can definitely diagnose shock for you. So for example, shock can present typically with hypotension and decreased cardiac output, but in some types of shock, the blood pressure will be normal and the cardiac output may even be high, and it is still a shock state. So this is the hard bit about diagnosing and spotting the shocked patients. So shock can be broadly divided into two big groups. The first group is shock with an impaired cardiac output. So the heart itself is not pumping enough blood peripherally. Or it can be with an impaired systemic vascular resistance. So the heart is pumping enough blood, but actually because there is a significant vasodilation, the whole circulation is just pulled peripherally away from the heart. Those ones with an impaired cardiac output can be because of either decreased preload, so the venous return to the heart is decreased, or decreased myocardial contractility. There is a good preload, there is a good venous return, but the heart is unable to push hard. Or actually the heart is doing the best, but there is a significant resistance afterwards. There is an increased afterload that is causing this shock. Regarding this one, where the other one with the impaired systemic vascular resistance, actually the severe vasodilation is the reason for the significant reduction in the afterload. And that's why those patients are shocked. So let's give it some examples to make it more understandable. The examples of shock with impaired cardiac output. First one, as we said, the first reason is decrease the preload. This can happen with hypovolemic shocks, whether you've lost blood, like what happens in trauma patients, for example, or you've lost fluids, like the patients with diarrhea and vomiting or patients with burn. So with those ones, you get the shock secondary to hypovolemia, secondary to decreased the preload. The second cause is decreased myocardial contractility, which can happen in cardiogenic shock, like what happened with massive MIs, for example. And the third cause is the increased afterload, which can happen with the obstructive shocks, like massive pulmonary embolism or tension pneumothorax or cardiac tamponade. So as a general rule, shock patients with impaired cardiac output, they are usually called peripherally due to the cutaneous vasoconstriction. So just bear that in mind as an important clue for your shocked patients. The other group is the shock with an impaired systemic vascular resistance, the severely vasodilated patients. And we call this type of shock the distributive shocks. The first example to this is sepsis. So septic shock patients are severely vasodilated in association with severe infection. And the anaphylactic shock, where they are severely vasodilated secondary to a massive histamine release, or the neurogenic shock, when they're vasodilated because of a loss of a sympathetic tone. So these are the three examples of the distributive shock. And again, as a general rule, shock patients with impaired systemic vascular resistance, they're usually presenting with warm peripheries due to the cutaneous vasodilatation. So that is another important clue that you can use to differentiate the type of shock. Okay, so commonly affected organs are, and those are the organs that you're going to focus on in your clinical assessment. So skin is an important organ here. The skin is usually cold, but it can be warm, as we said, and it will be sweaty. Kidneys, usually with shock, there will be a renal shutdown. And if the urine output is less than 0.5 ml per kg per hour, be worried. This is a bad sign. Next is the heart. So the circulation, as we said, you can have hypotension with tachycardia, but this is not an absolute thing. You can have shock without this. And you might get chest pain with your patients if they hypoperfuse the coronaries. And lastly, the CNS, the brain. Those patients can present with disturbed conscious levels secondary to the circulatory failure. How about the shock index? So shock index is an important term. an important tool that you need to know about because it will help you a lot diagnosing shock patients. Basically, you need to divide the heart rate by the systolic blood pressure. So you're not using the heart rate only, you're not using the systolic blood pressure, or you're using both together. So let's assume that your patient has got a heart rate of 70 per minute and a systolic pressure of 110. If you divide them by each other, you will get 0.6. Your shock index is 0.6. Normal is from 0.5 to 0.7, so you're fine here. What if the heart rate goes up, like what happens with shock, and the blood pressure goes down? This total number will go up, and this is bad. So let's assume that your patient's heart rate now is 100, divided by a systolic pressure of 100. If you imagine this patient, 100 of heart rate is not that bad, not that worrying. Systolic pressure of 100, again, not that bad. It is not ideal, but it's not too bad. But if you put them over each other to get the shock index is going to be 1. 1 is a bad shock index. Anything above 0.8 is bad. So actually, this is far more sensitive to spot shock rather than isolated vital signs. So that's the whole point. This is a very useful tool to understand the tachycardia within the context of blood pressure. And it's shown to be more sensitive than vital signs alone in diagnosing occult shock. And as I said, a shock index above 0.8 is bad. So let's move on to some pitfalls in diagnosis of shock. So relying solely on the systolic blood pressure as an indicator of shock, this can delay the recognition of shock because it can take a long time for the blood pressure to go down. And it might be just before the cardiac arrest when you get the significant drop in the blood pressure. So waiting for this to happen is not a good idea. Never underestimate the shock index. Take it seriously because it will give you better sensitivity in diagnosing and spotting those patients. And tachycardia and skin vasoconstriction are the earliest measurable circulatory signs of shock. So I always say this to my junior colleagues. Always feel the hands and the feet of your unwell patients. You will spot a lot just by doing this. And lastly, never underestimate sweaty patients. So as a general rule in emergency medicine, sweating in ED is bad. I've never come across a sweaty patient in the emergency department and it was a benign thing at the end. So it will be a heart attack, it will be an MI, it will be sepsis, it will be shock, it will be thyroid storm, it will be something bad. I know I work in United Kingdom and the weather here is a bit cold, but even in Egypt, I worked there for years and sweating in ED is bad. So I always say, if your patient is sweaty, you should start sweating. So elderly patients may not present with tachycardia at all for various reasons, whether this is a decrease in the physiological reserve or because they're already on medications that will stop their heart going up, the heart rate. So by all means, don't wait for the tachycardia in elderly patients to recognize that they are unwell. And massive blood loss may produce only slight or no decrease in the hematocrit and the hemoglobin concentration. So we sometimes get this from our junior surgical colleagues when they always ask in trauma situations about what's the hemoglobin doing. And actually, if you think about it, the hemoglobin is measured as milligram% or milligram per deciliter or gram per liter. So it is a ratio of the amount of hemoglobin you have in your body in relation to the plasma volume. When you lose blood, you lose whole blood, you lose the same amount of hemoglobin and the same amount of plasma with the same ratio. So if you measure the ratio that's remaining in the body, actually it will be the same. Then the body will try to correct itself during the shock state and will not be able to produce hemoglobin, but will be able to produce some plasma, and you will start giving some fluids, and that will dilute the remaining hemoglobin. So the drop in the hemoglobin and the hematocrit will happen late in trauma, will not happen early. So do not be falsely reassured by having normal hematocrit in a shocked trauma patient.